Hello, good evening, and welcome to our front. Tonight, we tackle the escalating brain drain crisis in Ghana's healthcare sector, now affecting top specialists and consultants. This recent wave has been brought to the fore by specialist neurosurgeon Dr. Hadi Abdallah, who has been highlighting this distressing trend where seasoned professionals are leaving for better opportunities abroad, finding that 5 years of work overseas offers a more secure retirement than 35 years of service in the Republic of Ghana. Joining me for this all-important conversation are medical officer, academic and health management expert, and currently presidential advisor on health, Dr. Anthony Isiasare. Dr. Richard Salome is the General Secretary of the Ghana Medical Association, and Kwame Siedu Sapon. Kwame Sapon Siedu is also the Democracy and Development Fellow at CDD Ghana. Of course, he's a pharmacist too. So it's an all-health related conversation. Together, we'll explore the causes driving this exodus, its implications on the country's healthcare system, and potential solutions to address the growing crisis. Now, let me start the conversation with the Ghana Medical Association, which we are told the members of which are leaving the Republic. As General Secretary of the Medical Association, how serious is this brain drain crisis among your members, particularly specialists and consultants? Dr. Salome.
Well, good evening, Raymond, and good evening to your listeners. Even if one doctor leaves, it's very serious enough. But this is getting to alarming levels. Currently, as we speak, from the Medical and Dental Council, we have over 100 people applying for clearance or certificate of good standing to enable them to leave their country to migrate to other places like UK, the US, Canada, and now Australia is coming strong, and even aspects of Europe. And this is very serious in the sense that, especially when it begins to involve consultants, out of this 100 and over, we are hearing that almost about 20 to 30 of these people are specialists and consultants. These are people who are very experienced. Beyond the skill set they have and provide services, they also are involved in training. And beyond just looking at healthcare as just some charitable entity, they also generate revenue and bring in some foreign exchange, because we are seeing patients flying from Liberia for various procedures that are not available in their places. So when we begin to see specialists and consultants with very serious experience leaving the country, that has serious implications for the quality of care that we provide. It has serious implications for training. It has serious implications for research and various aspects. And that also means that those that are behind them begin to lose hope within the system, and then be going to question themselves what they might be doing in the country. And so if you begin to see doctors, 100 and over, leave, applying for certificate of good standing for the Medical and Dental Council to enable them leave. And then also you are beginning to see WhatsApp groups, various pages on various social media pages where people who have just left school or even specialists have groups where they are studying to pass foreign licensing exams. That is a cause for worry. And so this is how serious it is. Remember that 100 may not look too large compared to some of the other professional groups, but when we do the relative per capita, that is even more serious than even some other professional groups. But of course, in totality, this is a very serious matter that we need to address urgently.
Well, I need you to put in proper perspective for me. I mean, you said over 100, and about those, around 20 to 30 of these are specialists and consultants. Now, has it been different from the trend over the years? On average, how many doctors intend to leave the shores of this republic, especially when it comes to the general picture? Then specifically when it comes to specialists and consultants, what's the trend been like? Is it been like 1 to 5 and now it's extended to 20 and it's becoming problematic, or it's always been around 20 to 30?
So the difficulty in assessing these issues is the fact that most of these are intentions. And when intentions are involved, it's difficult to judge because not everybody applying for this may be successful at the end or may actually leave the country. However, that intention is expressed, and this has been studied. And of course, in the past, we used to have brain drain where it became an alarming issue. Specialist training was instituted locally, and you had quite a lot of people staying. In the past, they had to go and train outside, and the exposures out there, looking at the economic situations and comparing it back home, many of them would not return. But localization of specialist training especially, and then maybe economic conditions at the time, then brought some stability to this. But of course, this has increased in recent times. And we are aware various studies. In recent, we ran some polls on our page. You have 80% and over saying if they had the chance, they were leaving the country. And then, as I said, in recent times, the challenge we are seeing is the fact that at first, these are young doctors, medical officers, as my president mentioned, I think during this week, who would normally leave the country because waiting for posting, they are not getting posting, and then some challenges with sometimes getting clearance, etc. In waiting, they begin to write these exams and then prepare themselves to leave. Now, we are seeing that specialists are also leaving, and we've counted quite a number. I've just been informed that an ONG specialist, I won't mention the place because it's not yet out, he's probably the only person serving about 2 or 3 districts. And this is somebody who has contributed greatly to maternal mortality issues across. And he is preparing to leave the country. He has just passed his board exams out there, and he's preparing to leave. Who is going to take care of those districts? So these are some of the seriousness. We've heard of hematologists. I mean, the one who used to be one of the deputy director or one of the heads of units at the National Blood Service is gone. We have seen emergency physicians, about 2 or 3 that I know personally in Kolebu who have left. Seen internal medicine physicians who have also left from Ridge Hospital, 1, 2 we've heard in the regions and in the districts elsewhere as well. So these are very serious times that we are in. And if consultants are leaving, this poses a serious challenge that we must address with very urgency that it deserves.
I will explore with you the why in a second, but let me get some understanding of what the figures are when it comes to government's own appreciation of this. And I did mention earlier on that presidential advisor on health, Dr. Nsiasare, of course, he's headed the health service before. He's also been Konfanochi Teaching Hospital CEO in times past. So he understands some of these issues. Dr. Nsiasare, you're welcome to UPFront. I hope you are doing well this evening.
Thank you very much, Raymond. I'm doing quite well. And greetings to your cherished viewers and listeners.
Now, let me start from the...
And also greetings to Richard and also Kwame. Kwame, I haven't seen you for some time.
Certainly, I should be able to bring in Kwame Saponesiedo into the conversation in a second. But, Doc, the numbers, according to the practitioners, are alarming. Over 100 applying, and also out of this 100, a certain specialized group, specialists and consultants, 20 to 30 are the ones that are part of those seeking some clearance, ostensibly to leave the shores of this country. The other things we've been told, and I did hear Dr. Salome mention that there's a poll also that they conducted, anecdotally suggesting that 80% of professionals on that particular page were willing to leave the country. He mentioned this ops and gynae specialist who is taking about 3 or 2 districts, who is also basically on his way out of the People's Republic of Ghana. Are these alarming figures that should put us on edge?
Yeah, thank you very much, Raymond. I think brain drain has been of us and of the African continent for a long time. One of the reasons is that you are all aware that we cannot compete, especially with remuneration and then also conditions of service with the European countries and also in America, that maybe now Australia. But a doctor who is finished medical school there are two reasons that a doctor may leave. And one of the most important reasons, as Richard earlier said, is for postgraduate or to upgrade a person's qualification. When we all go to medical school, we all choose where we want to be. So I want to be a surgeon, like I'm a surgeon. And then somebody say, I want to be a gynecologist. But the most important thing is that everybody wants to do this thing as quickly as possible. I'll go back into history. In history, if you remember, somewhere in the 70s, especially in the 80s, when I became a medical officer, a lot of our consultants and specialists had some appointments in Saudi Arabia and in the Arab countries. So some of them left to Liberia, and later on, so most of them came back. That time we were training. The only postgraduate training that we had in the West Africa sub-region, which Ghana was part of it, was the West Africa College of Physicians and West Africa College of Surgeons. It was not well structured. And if you remember, a lot of our young people those days were either going to Nigeria, also opened up in the 70s, late 70s and 80s. So most of our doctors were going there, not for postgraduate training, but mainly because Nigeria at that time was very buoyant and the economy was booming and everybody wants to go there for some money. So these are the two main reasons. So there's the reason one is for postgraduate education or to increase your resource, your money, and then your salaries and the rest. If you want to solve it, there are two ways of solving it.
No, we'll come to Doc. Just give me a second. I need to go around the table and get an understanding of how serious this condition is before we come to the solutions you are proposing.
Yeah, okay.
And certainly,
Richard is giving figures, but the best people to tell us that people are now going for certificate of good standard is the Medical and Dental Council. I'm here to get any figures from them, but he said that intention, because somebody can go for Medical and Dental Council certificate of good standard, either the person is going for training, or if the person has already trained, maybe he wants to migrate and go and work elsewhere to improve his system. So these are the two reasons. So until the time that we get figures from them and disaggregate it and know who are the young doctors who are looking for certificate of good standing and where the specialists who want to go and look for certificate of good standing, then we can put the figures into perspective. But so far as I know that most of the people who were living in this country were people who were going out, they've written examinations to go and do further training, either in Europe or in America. Anybody who has finished postgraduate and is a specialist, we didn't see much of them leaving the country. So if that's what is happening now, we'll find out. Because if you are here in Ghana and you finish postgraduate training and you want to migrate to US, you may have to go back and restart everything again. In Europe too, unless you want to go and be maybe a general medical practitioner there, or you want to be maybe casualty officer. But most people leave because of this. That's what I do. So I cannot talk to the figures now until I get in touch with the Medical and Dental Council and get the disaggregated figure. That to me would be the best way that we can discuss this thing fully.
I understand you perfectly. Let me bring Kwame Saponesiedu into this conversation. I mean, on the face of it, what you have heard about the numbers being brought to the fore now and the comments of Dr. Hadi Abdallah, Dr. Richard Salome, and the very things that's happening in the system, are we supposed to be on edge and worried about a trend? Is it something that should keep us on our feet and making us have sleepless nights?
Well, and thank you, and good evening to everyone. Good evening to Richard and Dr. Siasari. Yes, I am worried. And I am because I've got friends who I came abroad with and trained, who returned to Ghana. Some of them are professors in universities who have now migrated, upped their entire families, and left. These are my personal friends. So I'm saying that because I wouldn't want to put names out because they are inappropriate. But I'm saying this, these are people that even Dr. Isiasari knows. And I'll backstage him and give him the names because he knows us as kids. We are all Kumasi boys. So the people I'm talking about are people Dr. Isiasari knows. And it scares me. And you are talking about not just specialists, but consultants with professorial positions. Happen sticks with their whole family and leave. I also have friends who have trained and have done the training in the Ghana College, the West African College, and all. And I want to supply this information to Dr. Isiasari because maybe he doesn't know. Now there are routes, especially in the UK, where these specialists can come in straight and train as specialists. They are giving them routes because they need them. And I have friends, and Richard knows the people I'm talking about, so he's shaking his head because we talk in the background. I have friends. I'm not saying friends. But more importantly, I also have acquaintances, some friends as well, who even now you would find talking on social media saying that, oh, everything is okay, but have absticks and are in the UK and cannot even tell their colleagues that they've left the country. That scares me even more. And you see, when I'm talking, Richard shakes his head because we know these people. It's not that we are talking about imaginary figures. These are human beings we know, personal friends, some who we've even attended funerals with and taken pictures with. And it worries me because it gives me, I'm giving this whole broad place because it gives me a situation where we are denying the problem we find ourselves. And when Richard was speaking, he made a comment that 100 doctors is not a lot. But all of us who look into health policy, health statistics would know that a doctor leaving has serious ramifications because in healthcare, Dr. Isiasari has managed health systems more than myself or Richard have ever managed. So, and I'd always give him that credit. But he would tell you that you have one consultant, you have X number of specialists, then you have X number of senior doctors, house officers, blah, 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 pharmacists, nurses, and it goes as a pyramid. So depending on where the jigsaw falls out of the pyramid, it means by default you are losing recruitment opportunities further down the triangle. But when you have people living at the very top, it's even more scary because apart from them leaving as top consultants, there are professors who are leaving and are not doing the knowledge transfer we need in health. Because apart from everything, health is not just a science, it's a vocation. The longer you spend on health, the more your vocational skills improve. I wouldn't equate a surgeon who graduated or became a consultant 2 years ago to Dr. Isiasari. If I was to be put on the table, I'll go for Dr. Isiasari. It's common sense because I know his expertise, I know his track record, I can vouch for it, and if I'm going to do probabilities of survival, I'll go with Dr. Isiasari because I'll get there. And that is how it works. So when you have those likes leaving, then we have a problem. And the other thing that makes it even more of a serious problem is that a lot of the younger ones look out and up to these leading lights as reasons why they have to stay. And they are the ones who give them the sort of reassurance that at the end of the day, things would work out. And if those ones are going, then who is caging the situation? So when I read Hadi's post, I asked myself, am I being hypocritical here? Because obviously I live in the UK. I've been practicing in the UK for quite a while. I left as a lecturer from KLEST and left. So similar situations. And I was like, well, let me look at the numbers and do it again. Is he right in the remuneration aspect? Yes, he is. And I've listened to my friend and brother and colleague, who is the president of the Ghana Medical Association, tell me what he earned as a house officer and medical officer in dollar equivalent compared to now that he is actually a boss and he's worse off. So when you hear conversations like this, you ask yourself, do I expect Frank to be convincing people to stay behind when he knows that having spent all these years, he's actually worse off? So we need to have a bigger conversation. And I'll end this way. I remember when we graduated and before we were leaving, and when Dr. Siasa were in their mid-youth and they were in charge of the health systems and all that, and they were advocates. I remember Dr. Hineba Danso and co. advocating for certain leaders to be put in place for health professionals, like clearing their cars for free, certain servicing, provision, housing, and all that. And then when the colleges were brought in, first it started with the medical college, then the pharmacy college, then the nursing college, people found reasons to stay. How well are we lubricating these facilities to make it amenable for people to stay? I think those are the conversations we should have. But if we say we are going to deny that consultants are leaving, I will tell you that then we are behaving like ostriches. Because if I have one clinician, but I don't want to put his name out yet. In fact, Raymond, I've discussed it with you in public. But if I were to put out, I would put out oncologists, I'll put out urologists, I'll put out pathologists at that level who've left.
The question I'm asking is, we know that there has been brain drain in this country for a very long time. Is this current trend alarming? Is it?
I would say it's alarming, Raymond, because when we were leaving, the Dr. Siasa of this world didn't leave. That's the difference.
Okay.
And that's why it's alarming. And that is what Dr. Frank Shibor is alluding to. Because, you see, what you have to bear in mind is those professors and senior consultants that are leaving now are our friends from childhood. Some of them even went abroad and trained. I know one particular who actually trained abroad, came to Ghana, went to Germany, did his PhD and specialized and all that, came to Ghana as a consultant, was lecturing in the university, became a professor and has left and is in Canada. That worries me because this is a friend who had no intention to stay abroad because he left Ghana at a very young age and there's no motivation for him to stay abroad because every time he's gone, he's come back. But now that he's hitting the twilight of his career, he's just left with all the expertise. And anytime I speak to him, because I speak to him on a regular basis because we are friends, he says, Kwame, you know me. We grew up in Kumasi. We were all watching football together. You know how I'm fanatic about my football club in Ghana. But I have had to leave. That should tell you something. And Raymond, that's why these things worry me.
Well, that's an interesting perspective. Dr. Salome, I need to let you break it down for me. I've heard the comments about role models for junior officers and all the other things being said. I've also heard the comment about how this will disincentivize others who are down the ladder. But as Ghanaians who are seeking health care, how does the exodus of the likes of specialists and consultants affect me, who is more likely to walk to any health facility tomorrow to seek health care? How is it supposed to be my problem?
Well, before I proceed, let me just, as Kwame said, let me just add to what maybe Dr. Nsiasari. UK, which used to be very stringent, has actually created more easier paths for specialists to leave. Canada is doing the same. A number of states in the US now don't, even with Ghana College, would not require you to write any, some of those exams. You do pupillage under some consultants, and then they get you through the system. Some do require you to just pass an exam and go through. Australia is making it easy. Germany is making it easy quite a lot. So maybe in the past, it was those days. And to let you know why it is that serious, if you remember, earlier this year, the WHO itself had to put us on the red list, if you remember, again. And even though we've been in the past, they had to put us there to sort of begin to look at how we manage the migration of workers out there. So it is that serious. Now, for you as a person, I commented that on other fora that the Ghanaian cannot pretend to be a victim in all of this. The Ghanaian is the...
I suspect that I have some connection difficulty
who owns the ultimate power and whose responsibility in this. And the important thing here
Dr.
is...
Solomon, let me impress upon you to backtrack slightly. Okay, I lost you at the point you said something like the Ghanaian is not a victim in all of this.
Yes, so I'm saying that the Ghanaian is not an innocent victim in all of this because we own the ultimate power. And it is important that the Ghanaian begins to speak about these things and not leave it to only the professionals. Because if you do not speak about these things and you do not impress upon governments in the generic sense to ensure that these professionals stay, then you will be willing accomplices and actually accomplices in your own doom when the problems arise. How does it affect you? I have mentioned to you that we are aware of one obstetrician gynecologist who manages maternal issues, childbirth issues, various issues in that regard, and helps prevent in a serious level maternal mortalities in many of these places, managing about 2 to 3 districts under his catchment area. This person has just passed his exam and is about to leave. What that means to you, the average Ghanaian, is that that person in that district will have to be referred to a faraway center and will have to take a bus and go. The intangible cost that we know, you will have to travel with your siblings and other people to the faraway center at cost of accommodation, food, and other things. What it also means to you is that certain people, depending on the specialty, you may need to get out of this country. In the past, we used to have people leave to India to get transplants and co. And now we have specialists in-house that are manning some facilities that are able to do transplants, like happened in the UGMC recently and Kolegu. If these consultants leave the country, it means higher cost for you again to leave the country to begin to get some of this care outside the country. In terms of the government and the public in general, cost of running some of these places, UGMC has been built. It has a lot of fantastic facilities, but they are not fully utilized because we don't even have the professionals to man them. So if we run some of these facilities this way, there won't be people to run them. There will be cost to you in the long term because these facilities need to be run, they need to be powered, and they need to be used. So there are many implications for us as Ghanaians, and we have to take active interest in how health professionals especially are treated. Has it not occurred to you, and has it not strange to you, that all services that are deemed essential in this country retire on their salary at certain ranks? But healthcare is the only one that so far never retires on their salary. Certain ranks in the police, the judiciary, the army, etc. But the professors that people have talked about, Dr. Nsiasari's level and his contemporaries that we are talking about, who would work themselves off 35 years, 40 years, cannot retire on their salary. They retire on the regular pensions and peanuts. So if you examine yourself and your take-home pay cannot take you home, and your colleagues will point at you and tell you that he was a doctor for so and so, he did this brain surgery, he had transplanted hearts and co. But he cannot point to a serious thing. And one simple sickness can run him down totally into catastrophic expenditure. He begins to question himself and ask himself, what is worth dying for? You need to live to let live, and people are beginning to question themselves. So it is important that we take these issues quite seriously because the people cannot pretend to be innocent victims, but we are willing accomplices, and we must begin as people to demand this. Because, for example, the Agenda 111 hospitals that are being built, they will need people to man them, to bring the healthcare services, the specialized services closer to the people. If these people are leaving, certain people will leave and we may not be able to train others to take care of them. That becomes worrying. And so for you as a Ghanaian, this should be a priority matter that you should look at and appeal to whoever you know to ensure that something is done about this.
I heard Dr. Nsiasari say that, of course, higher level training is one of the reasons why people leave. But in Dr. Abdallah's Facebook post, he was categorical in drilling down to what he believes is the crux of the matter. He says, many have realized that working for 5 years abroad gives them better retirement than 35 years in Ghana. I will come to you, Kwame Sapon, on this one, since you are still working abroad. Now, let me get to understand it from you, Dr. Salome. The people that are intending to leave or have already left, what is the overriding factor? Is it in tandem with what Dr. Abdallah is saying, or they are just required better training?
Well, as our president clearly stated last week at the annual general conference of the Society of Private Medical and Dental Practitioners, the fundamental reason is economics. The buying power of doctors and other health workers has continually gone down, despite best efforts of governments over the years, successive governments, to try to improve their conditions. If the general economy is not doing well, it affects so many things that you can do. Generally, majority of doctors cannot walk into any showroom and buy a brand new car cash down. Most of us would have to import cars outside, second-hand cars. And in recent times, some cars that, for example, on hire purchase, many doctors would have practiced 10 to 15 years before thinking of even building a house because they cannot afford it. Many of the condos selling in Accra, most of the consultants cannot go and count and pay the $80,000 or $100,000 and put it cash down and purchase some of these houses. And so these are realities, especially when you notice that your salary, when you were a house officer or a medical officer, and then 10 years down the line, 7 years down the line, you convert it to dollars and you are actually down because your buying power is not enough compared to those days when you could actually import C-class beds, which many doctors and young people used to import using the car waiver. And now it is more difficult. Again, if you look at it, there are doctors whose wives or spouses' insurance with banks, airlines, and others is what actually takes care of them in facilities that they work in. They have to pay their own bills.
Really?
And so, yes. And so these are serious matters we are talking about. The economics is a key incentive. There are also others, when you look at discussions generally on our pages, for example, career fulfillment. People have specialized. They feel they can do a lot. They've gone to trainings outside, they come back, and then there are not enough tools for them to work. So they work. You sometimes have to see patients dying on your hands. You are referring a patient with an ambulance. There are challenges getting the person to a referring center. Sometimes you have to be funding many of these things from your pocket. And these has telling effects on you. You get depressed. Nobody is catering for that. There are no clear systems to take care of that for you. And so you go through the system, it gets to a point you break. There are many people, doctors and nurses and other people who have various mental health issues out of this work. Some have suffered work-related injuries. Beyond this also is the fact that many, especially in the rural areas, are working in places where there are not good amenities. I work in Ahafo. The road has been terrible from successive governments to that. I had a near miss recently returning to my facility from an outreach we went, and we almost got robbed. And robberies have been happening on these roads. There are good schools, very, very few and limited ones in town. So the question then is your acceptance to serve the average Ghanaian in these deprived or underserved areas then a punishment? Obviously, if you leave the country, you get better social services in some instances, some good schools, and some better amenities, and you know when you call the ambulance, it will come, and you don't have to think about even forcing yourself. So there are other related issues that make this, but the key underlying, as my president has emphasized over the time, is the economics of it. If people are paid well and the economic powers are good, what does a young doctor need? A car, a house for starters within the early years of their life. Soon they get married, they have children, then it becomes even more difficult for them to leave. And we must begin to look at putting these things together and say, if you work in the country for 6-7 years, you should be able to have this. There should be systems in place, and I believe there will be partners that can look into funding some of these things to ensure, because remember, as I've said from the beginning, health is not a charitable thing that we sometimes make it to appear. Health brings in revenue for the country. Health can bring in foreign exchange for this country, especially when we prioritize health tourism. And that is where specialist services and consultants become even more critical in this, to attract people in, to bring us the relevant, necessary foreign exchange to make things better. So those are some of the underlying issues that are in there. And but at the top of it is the economics of it.
Kwame Saponasiedu, give us an understanding of why it is possibly true that a man who is actually spending only 5 years outside, or as Dr. Hardy puts it, abroad, think that they are better off than working or have better retirement. Actually, that's the word he used. He said that it gives them better retirement than 35 years in Ghana. Is this backed by the actuals, the reality on the ground?
Well, Raymond, I'm sorry to say yes, and I like using personal experiences. Richard knows my dad. My dad worked in Canada, Israel, and the UK for part of his life, and spent most and decided to come to Ghana because there was no reason. He was doing well where he was. Would you believe that when he came to Ghana post-retirement, his pension that he received from Canada and the UK was more than his pension he received from the government of Ghana for the entire period? And this was someone who became the chairman of the Forestry Commission and the director of Forestry Research Institute of Ghana for a number of years. So I don't even need to go too far to realize that if you are retiring on the normal public service retirement package, what Richard is saying is what's going to happen. And so you ask me if that drives people away. Yes, that drives people away. Because at the end of the day...
But is this the most important factor?
And it depends on... I always go back to the Maslow hierarchy of needs. Human beings go by that pyramid, whether you like it or not. And at the bottom of it is what? Food, clothes, and shelter. And the next level is absence of fear. You understand me? Mm-hmm. So if food, clothes, and shelter is not available, especially as the person is thinking of marrying and having babies, and the security of having a decent road to drive on, yes, you don't need any data from Ghana to tell you that that would be a driver to send people away, because Abraham Maslow has researched that comprehensively. And so that, for me, is a non-starter. And that is why sometimes when we have these conversations, I ask myself, those we put in charge of making these decisions on our behalf, do they bury their heads in the sand and avoid these obvious truths? Because at the end of the day, Abraham Maslow lived long before any of us on this, program lived, and put these things out, and no one has disputed it to this day. So what makes anyone think that you can pay lip service to the people who are practitioners in any field and expect them to act contrary to what normal human beings would do if they had an opportunity to act otherwise? And so, Raymond, yes, the money is a huge factor. The second thing that probably is a huge factor is access to amenities and the future of their offspring. Because if that person was to go and live, say, in the UK or America and other things, that is working as a doctor or a pharmacist, you're sure that they will be able to put their children through some of the top universities in those countries. And therefore, that becomes a motivation for them as well. So these are some of the things that we need. And that's why I want us to have practical conversations about how to fix this. Because the drivers, we know, anyone who says they don't know the drivers as to why health migration occurs, it's being disingenuous. We know the drivers. And what we need to do is to find ways to ameliorate the impact of these drivers. If we don't do that, then we will not fix this.
Very well. Now, let me bring in Dr. Nsiasare. Doc, you heard the conversation. Of course, money matters are at the core of it. I'm not saying that you caused what they call depreciation of the Ghanaian cedi. I can also blame you for the current economic situation as an individual. But it's made it almost impossible for people to feel that they are better off in the Republic of Ghana. I know yourself, you trained in Germany, worked somehow, but came back to the Republic of Ghana. What is being done to stem this tide, specifically? Tangible, specific things that are being done to stem this tide. Yes, Dr. Nsiasare. Well, I seem to have difficulty reaching Dr. Nsiasare again. Maybe I'll roll back in Dr. Salome. Okay, so before I bring you, Dr. Salome, into the conversation, Dr. Nsiasare, I was asking a question about specific things being done to stem the tide. I mean, of course, they have taken Hippocratic oaths, or whichever words that they have taken, but they must survive. And they believe that it's becoming difficult for that to happen under the circumstances that we find ourselves here. Of course, you're talking about retirement and compared to other places. What specific things are being done in the health sector to make sure that we stem the tide?
Hello?
Yes, Dr. Nsiasare, yes.
Yeah, as I said earlier, this is not the first time that brain drain has hit Ghana. Brain drain has been there for ages. There are ways of mitigating it. You cannot completely eradicate brain drain in any country, especially from third world country to the developed country. We cannot compete with them, no matter what you want to do. But we do things to mitigate it and make sure that at least you cut down the number of people who are going. I still insist, for example, one of them is making sure that there is a structured, straightforward, agreed, and people very happy with postgraduate training. That's one. Second one is economic issues. You remember, at one time, I think somewhere in the late 90s, we introduced what we call additional duty hours allowance. And then later on, we consolidated the addition after evaluation of the jobs of all health workers. The salaries of health workers was consolidated, what we call the health services salary structure, HSS. There was HSS 1 for the medical professionals and the managers, and HSS 2 for other health professionals. Because the job of all health workers were evaluated, the job description was taken into consideration, the type of work that you are doing was taken into consideration, and also the risk to the work. And the ADHA was added, all the allowance were consolidated, and doctors were taken as part of the health workers from the what we call the GUS system, that the General Universal Salary Structure. And it made the doctor's salary and other health workers' salary relatively better, and then also the work that they are doing was at least paid for. If you remember very well, maybe Solomon and the rest were young people, or maybe medical students. Even doctors from Nigeria who train here decided to stay in this country and work. And that time, the foreign exchange, the exchange rate was almost 1 to 1 or 1 to 2. So if you convert that salary, that's what I'm sure the president, my president, Dr. Srivo was talking about. You can quantify that I'm taking this amount of money is nearly about the same amount of money I would take if I'm a resident in the US. And then we introduced the Ghana College of Physicians and Surgeons. So a lot of young doctors then stayed because we are on HSS up to, I think, 2000, and we had the HSS scale to about 2010, isn't it, or 2009, I mean, correct me. I remember very well, 2009, I remember very well, I was then at the tail end of my work as a chief executive of Konfanochi. So the chief executives of Konfanochi, the Director General of Ghana Air Service, and the chief executive of Kolebu all met the health workers one by one. In fact, we met them as a group. And we advised that maybe we have to stay at the HSS, not to go into single spine. That's the time. I think Richard, you remember, that's the time that the police have been paid. huge sum of money. Everybody said they want to go to where the police are. But it was the police were overpaid for one reason or the other. It was taken away again. And if you remember very well, I've been saying this at all AGMs, that some of us advise, let us stay here, because I believe that time that 10% of 1,000 Ghanaians and 10% of 100 Ghanaians are different. So if the other workers go for their condition of service negotiation and get 10%, we also go and say maybe we want 15%. And then if you settle on 10%, it's higher. Maybe we should have stayed there. But it didn't happen, and we went to the single spine. The spine of the single spine was so heavy that there was some allowances we were given, and later on, around 2012, if you remember very well, it was grandfathered. But still, people were leaving, but not maybe specialists and all this. The specialists maybe have started leaving because the countries that we mentioned, Canada, UK, and maybe Australia, they need the doctors. After COVID, everybody has seen that those who died from COVID, where the direct health workers, both doctors and nurses and other people who were working on the patients. So we understand that even, especially nursing, it's not so much attractive nowadays, for example, in Canada and also in UK and US. So that means people will migrate towards where there's increase in salary. They've opened up the system. You can enter the system without any much examination that was before. I just got to know from you now that now UK have waived some things, Canada has waived it, and even US is waiving because they need them. They need the people.
So what are we doing to keep them here?
I'm coming. Take your time. You've given them all the time to talk. No, I have to tell you because you gave them twice. They spoke everything. So if you rush me, then I cannot explain things.
I get your point, Doc.
So government have seen this. Government is aware of this. Every government should be aware that you don't want your health workers, especially doctors and very senior doctors, to leave. Some of us train outside. When I finished, within 6 months, I wanted to come home. I came home. I could have also stayed in Germany, but now maybe I'll be a post-retiree there and then enjoying my children who have gone to schools and all this. My children, by the grace of God, I've also been able to educate them, even here, with the scarce and the small resources that we are giving. So it takes all these things, we have to take all these things into consideration. And then you better the conditions of service of the health workers. Richard was talking about healthcare and all these things, the healthcare for the workers and all these things. And Richard, you know, I've been talking about this thing for several times. And when I was in Ghana, I wanted to use to do what we call the Health Plus. There's nowhere, and I'm sure Kwame will tell you, health is expensive. Anywhere that you are working and you want to have health service when you are sick, you pay for it. You pay for it either through your insurance, or if you don't have insurance, somebody pays for you. So we're trying to say that let's set up a system where we can take care of ourselves when we are sick without, and when we set it up, by all means, you get government to also contribute as a reinsurance system. And thirdly, if you want anybody to go to anywhere, sometimes I feel very sad. You send a community health nurse to a rural community where there's chips. I've gone to a lot of parts of this country because of Agenda 111. And then he's sent there, he should go and work. There's no accommodation. Where will the person stay? So we also believe that there should be a medical village at wherever there's a hospital which has been established. And to me, that medical village should not just be a medical village. That is where the rural incentives come in. That is where you can say that you can stay in that place, a 2-bedroom, not even one single bedroom. I believe in 2 bedrooms, well furnished. The person moves in, he takes his or her bag and goes there. And that is how villages and towns are developed. Where they can have a commercial center and everything. We have seen it in this country. If you go to Kumasi now, the appeal court judges have an appeal course, isn't it?
Yes.
Near the residency. I believe that the same thing should happen in all the hospitals that we are putting up, and even in the old hospitals because they have land. So there's a medical village, the doctor or nurse have a place to put his or her head. He has also a very conducive atmosphere to work. And wherever the person is staying, he can then improve on him or herself and upgrade him or herself. So that we decentralize postgraduate education both for I'm talking about doctors now. And then we have a lot of people moving out there to go and practice and then learn, even get a lot of patients to practice with. And the consultants, one consultant, to me, should not be a consultant in one hospital. I think, Kwame, you know about that. You don't sit down and say, I'm only consultant in Charing Cross Hospital. You be a consultant in Charing Cross Hospital in other hospitals. Where when you go and give service, as Richard has been saying, that it creates money and you are paid for. So that these are the extra money that you get because you are using your extra time to do other things. So if you add all this together with rural incentives, with deprived area incentive, deprived departmental incentives, then you can then motivate people. It's not only the quantum of money per se, but the person wants to get something and notice that he can at least look after the wife and the children and the family and do things for him or herself. And that's what brings in a credit system where the credit system will be in such a way that you can pay for things yourself. Nobody anywhere can walk into a showroom and go and buy a new vehicle. They go through a credit system. Kwame, isn't it? And when it is there,
not always.
Yeah, not always. But if I'm even in UK, I will not take my money and go and buy a car when I can get a credit system. I won't do that. So I will use the money for something else. So to me, there is a multiple solution that we have to do. We have to first look at the salaries of health workers and for that matter, all the other workers. We have to look also at the training and then the continuous professional training and upgradement of all these health professionals, especially doctors. We have to decentralize postgraduate training that everybody has an opportunity to do a postgraduate. And if the person wants to go out there to go and maybe improve himself or get more money or this, you cannot stop the person. But once you put all the mitigating factors to the push factors so that we continue to keep the people here, a lot of them will be trained and then kept in this country and then work for the good people of this country. That to me is the solution to this.
Dr. Salome.
Where we are now with it's a free market that we have in this country, you cannot physically stop anybody that I want to do. And Raymond, you yourself, today, I'm sure, if you work and you get a job and you can get to BBC, you will go. Because the amount of money you get in 5 years will also be more than maybe the 35 years that you will be at where you are.
I'm not so sure, but I mean, that should be fine. But Dr. Salome, are these enough proposals to not only stem the tide, but at least control the current situation? Sorry, I seem to have difficulty with...
Sorry, can you hear me now?
I can hear you perfectly, just briefly.
Interestingly, when judges are being built, judges' villages near the same residency in Kumasi, doctors are being evicted and the land is given to developers to build and the doctors are being evicted. So clearly it tells us what we value and the consultants and who live in these same areas. And so I think we need to pay more attention.
Richard, I think you are this one. You don't hit it below the belt.
No.
It was a problem which I think has been sorted out. So don't let it be labeled.
Okay, I think your clarification has been made. Dr. Salome, I want to hear you.
I will let me.
Dr. Siasai, my time is running out. I'll be very privileged if you allow. Yes.
I think that some of the points he has made are valid. These are things we have been going into. For example, the issue about rural incentives. We've discussed this. It's sitting at cabinet. We have heard nothing about it for quite a long time now. And it's not only applicable to doctors. There's the financial components of it, and there's also the non-monetary components like promotions, scholarships for those who serve in rural areas, etc. I'm of the view also that it's important at this stage to look at retirement on salaries, and then also some health package. I think, Dr. Nsiansari, you mentioned this issue about the health matter. You know very well in what those issues were, in the sense that the employer has signed up to take care of the healthcare needs of the workers. And so if the employer is not committing anything, that is why unanimously all the health worker groups agree that no, you can't take money from us and use that to take care of us and say you are taking care of us. And so those are some of the reasons that was kicked against. But I think that if you take care of the key recurrent expenditure items for health workers, the issue about the healthcare, retirement on salary, rural incentive package, and improve the general economy, a lot of these things will go. I made a proposal. The general person working in the healthcare space, a young man, young lady, wants a house to start life with and a simple car to move up and down. If governments could consider offering a package of a house and a car for working for a certain period in a designated place, where people work for 7 years or 10 years, we can discuss this and Georgia, bring in bankers, bring in other private sector actors to fund this so that when the person works here, a consultant is coming here, he knows that he works for 5 years, he would have a car and a house at his disposal.
I'm grateful to you, Dr. Salome. I'm also grateful to you, Dr. Nsiasare and Kwame Sapone-Siedu. I'm ever grateful to you. Unfortunately, I've run out of time. Many thanks to you for joining this conversation about this creeping crisis of a brain drain in the specialist and the consultants range. Many thanks to you for joining today's Upfront.